get everything taken care of.
All right, so Dr. Cary, as you can see, is Medical Director of Pulmonary Function Testing at Swedish. He's been a friend and a colleague for decades, and was kind enough to give us a talk this morning on pulmonary function testing and whatever else he's got to teach us. Go ahead, Jeff.
Okay, thank you, Len. Yes, Len and I have known each other a long time, and as Len didn't tell you, we've been working on this talk for over 20 years now, trying to get this done. No, there's been a few hiccups along the way, and this year on this beautiful, nice morning, we have the chance to do this, and so we'll go through these slides. And basically, my plan really is to sort of take spirometry, go through that on some updates, and then move on to a few other of the services we can do in the pulmonary function lab. So I kind of adjusted my talk to include pulmonary function tests, encompassing information with pulmonary function testing and rounding up new and somewhat, I think, exciting pulmonary function applications. I have worked and do work as a speaker at times for Mylan and Genentech. And I first wanted to start with this. I think there's no more dominating thing these days than the pandemic, and I thought we should have something that goes back to the Renaissance time period for a little art history. So I saw this quote, now that I've lived through an actual plague, I totally understand why Italian Renaissance paintings are full of naked fat people lying on couches. And I wanted to have you look at this Venus of Urbino by Titian. And for those who haven't had enough art history yet to enjoy this, I think that we all feel like we could relax a little bit more, stay inside, and avoid all the challenges of social distancing and the issues related to to masks and everything, and sit on couches and be cared for. But because we can't, we'll talk a little bit more about pulmonary functions. And as I mentioned, spirometry, lung volumes, diffusion, and exercise are the topics I wanted to review with you all today. The material on spirometry really comes from a standardization of spirometry on a 2019 update from ATS, American Thoracic Society, and European Respiratory Society, recently published as an update in the American Review of Respiratory and Critical Care Medicine. And a lot of this information is not radical, but incorporates some of the newer ideas on how to look at spirometry. I think that, and you all look at spirometry like I do. It's a great tool, yet it can be very intimidating. It can take large, very successful clinics, and if you ask them to do spirometry, it can take them to their knees because they cannot deal comfortably with the goals and requirements. So this update, I'm not sure if when you look at all this, and many of you have probably seen it, whether this is going to get people back up and working or make them even more intimidated, but we'll go through it. Spirometry basically measures inhaled and exhaled volumes of air, as you know. It's an office test, which makes it very attractive. It takes 10 to 15 minutes. In the old days, I have a new slide. I will tell you what the spirometry takes in the era of the COVID world. So it's changed a bit. It should include the ability to look at both flow volume loops and volume time curves. And we measure FEV1, forced vital capacity, and ratios. And it's needed for diagnosing obstruction and can rule out restriction if FVC is normal but not adequate for making a diagnosis of restriction when FVC is not normal. Other tools are needed. And post-bronchodilator study also has a role we'll talk about. And this is really just a review kind of where we are with all this. Measurement of lung volumes. There's the tidal capacity and functional residual capacity. We'll talk about that. And there's body plethysmography, gas dilution, nitrogen washout, and just looking at an X-ray. I know that those of us who do pulmonary medicine are always amazed to look at how well radiologists can talk about lung volumes just looking at X-ray and also make a diagnosis. But my name on the form for the request, I see most every one of my patients gets a diagnosis of COPD no matter why they've gone there. The diffusing capacity is something we're going to go over. And this is a little more complicated. I'm not going to get through the entire picture of how that diffusion works. That's a talk by itself. But just at least go through that so everyone's aware of how that fits in with the testing. It's technically more difficult. You need a good tech, and you need to be able to sample the gases the right time. And here's something related to the update study or article that I discussed with you, the contraindications, quality assurance, all of these things. We won't go through every one of these, but they made a point with a large committee to go through and talk about these issues. And then I picked and chose several of these points to be able to maybe add on to kind of some newer concepts about where spirometry is and what kinds of things should be avoided and not avoided. And then I think we'll just start out with the forced vital capacity maneuver. As we were talking, the maneuver involves a maximal inspiration, and we'll talk about that, blast of expiration. The whole point of complete expiration has taken up much material and thoughts about how do you achieve that, and I've got some points about that. And then you inspire back to maximum with maximum flow back to maximum lung volume. So this slide is to show those individuals who come to the lab who are maybe a little more timid than they should be about blowing the air out of their lungs for getting their spirometry going. It's a deep inhalation. The blast, I think, is pretty well managed here, showing in this fire eater how that should go. And it should go for at least 6 seconds, and that the PFT tech should always dramatically go through these steps and use exaggerated body language. The problem with FEV1 measurement through spirometry is that it doesn't often fit the criteria that are established and we'll go through, and trying to get a routine down is awfully important. And the indications for spirometry, and we obviously aren't going to go through every one of these, but this is from this new update, and it's to go through from what a lot of you all see will be the symptom, signs, laboratory test results that are abnormal, and you're trying to see if airflow obstruction and restricted lung function is playing a role. It looks at patients with pulmonary disease or that you're thinking may have pulmonary disease. Preoperative risk is important and prognosis is important. And we have a couple slides about that. Monitoring, how do we assess therapeutic intervention? How do we monitor FEV1 with certain drugs and so on? How do we look for adverse effects of injurious agents, chemotherapy and so on? And disability evaluations, how do you look, or impairment, and how do we look for rehab? And then research trials and pre-employment, a lot of other ways spirometry can be used. So this I had to get, again, right back to where we were with the most current book, In the Room Where It Happened. This is the room, is the PFT room, and spirometry in the COVID area is not like spirometry that we used to believe. It has totally changed. We've changed the room. We've changed the whole pulmonary function lab. Now there's the personal protective equipment everywhere, sanitizer for the tech, and in between every patient, the important filter for viral and other bacterial and other irritants are changed between patients in our system. The pneumatic is changed, and the tubing that the patient hooks up to is also changed. All unnecessary material. It used to be that you could bring in half of a party into the pulmonary function lab or for spirometry, and they'd be able to sit around, watch TV, enjoy getting caught up. There is nobody allowed in these rooms now. There's the tech and there's the patient, and there should be nobody else there because of all the risk of the coronavirus and other potential respiratory irritants, obviously. After the equipment and the spirometry has been done, There's a thorough wipe down and equipment. There's hand sanitizer for the patient when he or she comes in, and the patient remains masked up until the test and gets a mask put back on right after the test, even though we've done a safety pause. We've reviewed a COVID swab that's been done within 48 hours, and we've done a new viral questionnaire about fever, exposures to patients with COVID, and about anything else that would suggest illness. So there's no extra individuals, as I mentioned, and then the patient leaves right away. There's no chatting or discussion of whether or not there'll be a baseball season. So that's really the new room, and it's what's made getting pulmonary function labs back open a bit of a challenge for everyone. And the contraindications, and you have copies of these, but it's really cardiac contraindications. If you've had myocardial infarction, if you've got blood pressure abnormalities, heart failure, and we do get a lot of patients that are referred to us from the cardiac heart failure program, so we're aware of that. If you've had some neurologic event, concussion, brain surgery, sinus problems, if you've had a recent pneumothorax, thoracic surgery, pregnancy, or if there's any infection, worry, TB, of course, some of the other viral infections. So those are all really important to keep track of. And then the activities that should be avoided, no smoking, vaping, water pipes, intoxicants. We actually, in spite of the fact that that seems, illogical to have those being used prior to pulmonary functions, some people do come in with that state in mind. Vigorous exercise, because of the potential of being on exercise-induced bronchoconstriction and wearing clothes that prevent full ability to cooperate with the study. And all this really comes from that update that I talked to you about. The other thing that I'm certainly no expert on, but our PFT lab techs are the whole maintenance of daily and annual and other evaluations for our equipment, which means that the 3-liter syringe that's used has to be recalibrated and sent to the manufacturer or to a local business that can do that for us, and that the 3-liter syringe is looked for any kind of a leak on a monthly basis. You look for smooth operation, and there should be accuracy down to 0.015 liters. Spirometry leak is looked for every day. Biocontrol is done with a volunteer who is the biocontrol subject for the lab, either weekly or bi-weekly. And this is all put into a log control where reference calculations and the findings can be found by anyone who needs to come through from agencies and so on. But the people who do this and will be doing other things with the equipment will be, I will mention, obviously the techs perform a vital role in this. And I think for people who don't do it enough, feel more intimidated by that. And here's the typical full volume loop that you get. The full volume loop includes the expiratory limb, inspiratory limb, so no cough or hesitation here, no premature closure of the glottis here to prevent the flow rate from coming out. And then on this side, there's a volume time, and that again looks at this plateau that should be maintained for 6 seconds at the end. And you all who have had spirometry realize how difficult that is without going into spasm or gagging or other things that are feeling like they're going to become syncopal. So all these ideal curves look great, but when you get a patient who's got disease or isn't particularly absolutely cooperative, that could be a problem. And so we'll show some examples. Basically, this new update from 2019 talks about this plateau time curve. I just showed you that time curve at the end. That's the curve here, and they spend a ton of time on that. And that's again why this can be so intimidating. There should be less than 25 cc volume change over the last second. Not many people certainly can get that stable. If not, multiple vital capacities that are repeatable can be substituted for this. Or some people have this ability, although if they do, they should be considered for America's Got Talent to be able to keep a forced expiratory time going for 15 seconds. That would render most of us unusable for the rest of the day. Expiratory time, it needs to be 6 seconds at least, and I showed you that on the curve, 2 seconds for children. And like I say, for children, the severity is not as much of a criteria as it has been in the past. Incomplete expiration will result in forcefully low, and I'll show you a picture of that. So if somebody blows out half of a curve, they're going to get a low vital capacity and a high FEV1, so you're going to get funny numbers, and the tech should be able to point that out to you. All right, and this is just from this paper that shows that you can get your vital capacity maneuvers either way: tidal breathing, inspiratory capacity, then blowing all the air out to residual volume, and that's expiratory vital capacity going up here, or you can do tidal breathing and do an inspiratory vital capacity and then blow the air out. So depending on the tech, they can get their vital capacity either way, but it's just noting that you can measure the volumes. This is the point at the residual volume that it gives you the measurement between total lung capacity and residual volume, which is vital capacity, as you are all aware. And that's just pointed out. And then what about the start of the test? That's also a big point of emphasis in these articles. There has to be, as you saw from those curves, takeoff without much delay. Otherwise, you're extrapolating backwards and making a new starting point. I'll show you a picture of that. And a large area where you do have this back extrapolation can make things look erroneously high in terms of FEV1, and you want to have repeatable peak flow. So I'll show you those pictures here, so that when we're assessing tests, we look at acceptability. The technician should be commenting and putting error messages in, and you'll see with new equipment, and I'll point that out as we go through this, that new equipment finds all this for you. Neither the tech nor do any of us need to go back and find these variabilities in patient effort, lack of the right starting time and the right plateau, because the equipment will be managing all this and telling you that as you look at the equipment and get a grade for the test. So some of the things that can happen that we've seen is cough or glottis closure, that there's a leak, so that there is a leak in the pneumatac or in the mouthpiece or whatever. The mouthpiece could be obstructed with tongue or dentures. There could be extra breaths, and there may not be an inhalation limb that's total. I'll show you some pictures of this. What goal we're trying to get is 2 repeatable trials where two of the FEV1 and VC ratio, should be repeatable with 3 acceptable trials. And you look at the 2 largest FEV1 and forced vital capacities, they should be within 150 cc's. I know this is kind of burdensome, but the nice thing is that all the new equipment automatically measures this. The best test is defined as the trial with the largest sum of the forced vital capacity and FEV1. So that can come from 2 different tests. So you can say that one spirometry had a better forced vital capacity, another one had a better FEV1. You save 3 test maneuvers, and then this is just going through how you go step at a time, making sure that each of these criteria are met, that 3 acceptable FEV1 to VCs, they don't need to be from the same maneuver, that if forced vital capacity and FEV1 are acceptable, if there's less than 150 cc's difference between each of the trial, the reproducibility, it gets graded, and you do no more than 8 maneuvers per patient because of fatigue and senses of pre-syncope and other kinds of adverse effects that may be brought on board. So we basically go through this and mention things that I just put on the prior slide, so I won't go through that again. I'll go right to the back extrapolation issues. So in this issue where there is a curve where patients didn't start at the 0, 0 time and start their exhalation here, but they were slow to start, you can back extrapolate with this line. And again, the machine does this for us, the newer equipment. And as long as this fits in with the goals that it's less than 5% of the forced vital capacity, you can take this as the new starting point. And this would be the way you measure the FEV1 from this curve and the measurement of your volume. So it's just important to note that it all sounds very complicated and more challenging than it needs to be. But the good news is that the machinery now looks at all this, automatically does your extrapolated volume, and automatically makes your adjustments for you. This summary just talks about the clear, quick start, free from artifacts. We talked about that. Satisfactory exhalation. The repeatability is necessary, and you can continue trying to test up to 8 maneuvers. There's certainly some patients that cannot really get to the part they need to be, even with 8 maneuvers. You take in the largest breath. You quickly start with this blast that I showed you, and then you have a duration of exhalation that needs to be the right number of seconds. And as we said, that's a minimum of 6 seconds. What about the hazards? No cough or glottis closure, no leak, no obstructive mouthpiece, no extra breaths, and complete the inhalation limb. And so there's a few of these curves that the tech should see, the machine should see, and actually the interpreting doc doesn't really ever see because they're not considered acceptable. So here's someone starting out, and as they do, they have coughing, they may have airway irritability, and that's unacceptable. It may come out to be a number that doesn't look too bad, but it certainly doesn't look like the best effort there. And it's characterized by these sharp changes. And I just have a couple pictures of that and showing what it can do. Here's an acceptable tracing here, and then these are unacceptable tracings, B and C, that show some maximal efforts. And with all the time I've been doing this and with many labs and working with many techs, I still see things not quite this bad, but areas that are clearly submaximal that are snuck through. But that again is more a reflection of older equipment. The newer equipment will not let that happen. And here's situations where there are hesitant starts. Somebody goes to start, kind of slows down and starts again. And then here's situations where there's sub-maximum tests and so on. So there's all kinds of varieties, but those are all recognized as whether it's sub-maximum, like this test was sub-maximum, looked pretty good, but clearly it's the same patient and it's not getting to the point where maximum effort and maximum values were obtained. So here's one where short exhalation time, somebody said, I'm gonna blow it up, but there you are, it's 1.5 seconds, 2 liters come out. It's clearly not adequate, even though you're gonna get numbers. You're gonna get numbers that are misleading because you have a volume of, just over 2 liters. You have a time, instead of that 6 seconds, of over 1 second, or just about 1.5 seconds. So clearly that would be thrown out as well. Just some things to remember, and some things that make, again, doing spirometry and believing in the data is somewhat difficult. So now that you've got all that in mind, if we want to know whether it's normal, obstructive, restrictive, or a combination, and one of the big challenges I see, and I think that in places where they're doing primarily forced vital capacity maneuvers, the issue is how do you deal with a low forced vital capacity? Does that say that you have restrictive lung disease? We know that a normal forced vital capacity says you don't, but what about a low forced vital capacity? And there's different ways of looking at this. Here's FEV1 to VC ratios. Now, if they're normal here and you have a normal forced vital capacity, you're fine. If you have a normal ratio and a low forced vital capacity, then you know that there may be a low total lung capacity. But as we discussed, you do need to do a test that measures lung volumes. Normally, that's a nitrogen washout type test, or it's a plethysmography type test. And so if you have a low FEV1 to VC ratio, and this comes to how we grade test, and normally we think that we're doing the right thing if we have low ratios. I think most of our days are hopefully occupied with patients who have airflow obstruction and not with patients who have normal flow rates, because they have severity based on their predicted FEV1s and other values, and I'll go into that with you. So here's the issue of what do you do when the total lung capacity is less than the lower limit of normal? Well, then you can do a total lung capacity by plethysmography, nitrogen washout, single breath test, but the best and most accurate is the plethysmography. But there are other tests that can help you with that, like nitrogen washout. Now, what about when the vital capacity, because here we have situations where we have forced vital capacity and it's less than the lower limit of normal. And a lot of times I'll see people say, well, your forced vital capacity is 75% of predicted, you must have restrictive lung disease. And that's always hard to know whether that might be patient effort, maybe air trapping, or a variety of other issues. And the issues that where studies have looked at this say if the vital capacity is less than the lower limit of normal, it can be associated with a low total lung capacity in up to 50%. But if the vital capacity is greater than the lower limit of normal, it's associated with a total lung capacity that's greater than the lower limit of normal in 97%. So yes, you can say that a normal forced vital capacity is associated with a normal total lung capacity. On the other hand, a low forced vital capacity, it may or may not be associated with a low total lung capacity, and further workup with these studies is necessary. And that's key because the ratings and everything are all based on that. So this is what the machine is looking at now. It's much more complicated. This is from that paper that I mentioned to you, and the machine is screening all this information. And I'm certainly not going to bore you with all this, but this is the back expiratory volume and how much, how these criteria are. This is the 0 settings, no cough, no glottal closure. So all of these terrible events that could occur and make the tests inaccurate are all screened for. And then the machine looks for accessibility and says yes to FEV1 here, and for these episodes for forced vital capacity says yes. And then there are requirements for usability, and the same thing comes up here about issues with how the patient comes up with signs of obstructed mouthpiece, leaks, the end expiratory takeoff, where you have to recalculate that level in terms of the back expiratory volume. All those things are looked at automatically now. So if you have a new spirometer or it's time to buy a new spirometer, you'll see all this stuff comes up, and when you talk to your tech, he'll tell you that that's all coming up, and he'll tell you when they're thrown out and make a comment in your notes that test is not going to be valid. And this is kind of what you see. You get a grade A, B, C, D, E, and then it's not usable, or it totally fails. You don't even see it. So to get a grade A, you have to have 3 acceptable maneuvers. It has to be within 150 cc's, as you know, and we're not going to pay too much attention to the less than 6-year-old, but there are particular criteria. It becomes a B, a C with 2 acceptable maneuvers that are 200 cc's in terms of reliability, and then that goes down to 2 within 250 cc's. So there's so much variability that you wonder about certainly the usefulness and accuracy. So it's good if you all have the opportunity to look at a spirometer and see this data that comes out. When I interpret this information, I always get this to look at. And I realize these spirometers are at different ages. Some people have spirometers that are somewhat older than this, and although I'm not trying to sell people more spirometers, I am saying that getting a spirometer that gives that data will help maintain the accuracy and the confidence of the pulmonary function test and the data that comes out of the lab. So now that you're all squared away with that, let's just talk about obstruction a little bit, and the fact that we have 2 major guidelines, because what's obstructed in some guidelines are not obstructed in others. The whole idea is obstruction is based on the FEV1 to VC predicted. It may be an overestimate in patients that have restrictive disease and have a low forced vital capacity, but a high FEV1. And so they tried with these different systems to come up with a plan that works. Here's an FEV1 to VC ratio concept that corrects for reduced lung volume. So if it's somebody who's has a small FEV1, I'm sorry, a small forced vital capacity, a lower FEV1 will help correct that. But there's a lot of debate about it and how to do it. And the two major bodies that you and I hear about are the ATS-ERS, American Thoracic Society, European Respiratory Society, and they use the lower limit of normal. The machine should look and give you the lower limit of normal. The gold symptoms, that's the guideline for obstructive lung disease, which nobody can go through life these days and not hear about the new gold guidelines. I will say that, they've been around for 10, 12 years, and each year they're able to change the gold guidelines enough to make us go back and look and see just what is new in the gold guidelines and what makes sense. So anyway, the problem is whether you're an ATS-CRS person or a gold guideline. And so here they are in all the color that you would want to see early in the morning. Here's ATS-ERS. FEV1 to VC ratio is all based on lower limit of normal here, where the gold guidelines are stable. You can be 9 years old or 109 years old, and what they're looking at is an FEV1 to VC ratio of less than 0.7. And then they're talking about when patients fit into obstruction. Once you fit into obstruction by ATS, it's when your lower limit of normal is met. When you fit into obstruction by gold, it's when you're less than 0.7 for this value. And then you look at these numbers, mild, moderate, and you can see that percent predicteds aren't quite the same. So to be severe in the ATS, your FEV1% predicted is 35 to 50, and severe here is less than 50, and very severe, less than 35 and less than 30. So no matter what adjective you use, you end up with a reference to something that you can probably find on these scales. So you can always say, if somebody says this is moderate in my scale, you can always say, well, I use a scale where this is moderately severe, and get away with it for a little while. But it would be nice to have this more uniform, because ATS-ERS is certainly a larger worldwide center, and yet gold is something that I find most medical students, residents, all kind of think about things with gold guidelines. And so here's just an example of male predicted and lower limits. So here's the male predicted here, going with an FEV1 to VC ratio of about 85%. And as we get older, it won't be a surprise for any of you to notice that you lose your ability to get the FEV1 out as quickly, so your predicted ratio falls. Now here's the gold guys. They're 70% your entire life. That's the one thing that you can count on, that your FEV1 to forced vital capacity ratio will never change between ages 20 and 90. And so as a result, if you go by the lower limit of normal, and therefore this is the lower limit of normal here, so anything in this area would be a false negative according to the gold guidelines, which would have said these people who have an FEV1 to VC ratio up here, but a normal FEV1 to VC ratio by gold guidelines would be a false negative by gold, but would have some obstructive lung disease by gold guidelines. And then on this side, there's false positives. Whereas getting out into older ages, which is more relevant probably, we don't get a lot of 27-year-old Amazon millionaires coming in who worry about their FEV1 to VC ratio, but we do get a lot of people who are older and want to know if they have obstructive lung disease. And here are patients that their FEV1 to VC ratio by gold criteria is 70%, and yet they would be normal here, but if they live in this area and they have an FEV1 to VC ratio that is, say, 65% or 60%, according to the ATS criteria, they would have obstructive lung disease. And as they get further away, and if we just take 70% out here by 90, these people have a ratio that is low and have obstructive lung disease. But if we use the gold patients just to have the FEV1 to VC ratio of 70%, these people their obstructive disease is not found. So anyway, you can find anything you want depending on the two scales. And as we go through spirometry, we look at the flow volume loop. I just want to say a word about that. This is one of the most common things I see, where the expiratory limb of the flow volume loop looks fine. The inspiratory limb is cut off. It should be as large as the expiratory limb. This is often due to patient effort. And I often read that as saying that the patient should go back and get that tested again. And that's why I have this slide saying most common cause of inspiratory limb flattening is submaximum effort. And I see that all the time, and yet I have to make a statement about it because there are situations where, especially now that we're doing all these percutaneous trachs in the ICU, and they get subglottic stenosis in a few of those, and when they do, that's another cause for this flow volume loop. And a couple times a year, we see this happen where we get this flow volume loop that looks like this. The expiratory limb is fine. Inspiratory limb doesn't look as good. So expiratory limb is blowing the air out. So this stenotic area gets blown out because the airway pressure is positive here. When you breathe in, you suck in air and you make this obstruction more dramatic, and the inspiratory limb becomes more dramatic. So my only point about this is to look at the inspiratory loop, and number two, that it may represent real disease. I mean, anything from something like this, which ENT can fix for us, or fixed obstruction where the vocal cords are paralyzed. And in those situations, you get a rounded curve like this. And this can come from tumor or other things, so that the expiratory limb and the inspiratory limb are both affected. So keep an eye on flow volume loops, and that's a big point of the way the curves are looking. So bronchodilator response, that the whole key is to make sure you use 4 puffs of the bronchodilator, that you look for an improvement of 12% to 200 cc's. Doesn't distinguish asthma for COPD, but it may, those people that are bronchodilator responsive may have a better outlook. So we can talk more about that if we have time. Anyway, here's a couple of cases I want you to review for me in your mind. What about this patient who came in to the office with really bad obstructive lung disease? And I will say that this FEV1 is 0.5 and they go to 0.6 and they got 24% better. Does that patient meet a criteria for bronchodilator response when it was really 100 cc's? And I will take away the suspense here by saying that when the FEV1 is less than a liter, 100 cc's is a positive response. So if I got this patient and I looked at that patient, I said, that's 100 cc's improvement, 24% improvement in the FEV1, but 100 cc's between the pre and post, I would want to take this patient with bad obstructive lung disease and treat them with bronchodilators. So there are different ways of taking a case and trying to make a statement, and I'll show you a couple other thoughts about this. Here's somebody with all normal function. Should this person have received a bronchodilator? Here's this person with an FEV1 of 3.1, close to 3.19. They got 3% better. What do you think about this? I see a lot of controversy out there about who gets bronchodilators, and now in the COVID world, because a lot of people worry about nebulizing a bronchodilator and then getting the secretions and the moisture from somebody's forced exhalation out there. They don't even want to have a bronchodilator around. But it does turn out that really bronchodilators and responsiveness changes a lot. So in this gigantic study of 8,000 patients, 3,700 were given bronchodilators. A lot of these had normal spirometry, and it turns out that the FEV1 by itself tells you whether or not you're going to get a bronchodilator response. So if your FEV1 is normal, none of those get bronchodilator response. If your FEV1 is 90 to 100% predicted, it's not below the lower limit of normal, but it's not normal. 2% of those get a bronchodilator response. And if it's below the lower limit of normal, 7 to 8% get a bronchodilator response. So I think that's important to know, that people have bronchodilator responses depending on how much airflow obstruction they have. I'm a proponent, I will give you kind of my editorial with this, and that is to say that we see patients often once, and I'd like to get full studies, including bronchodilator responsiveness, because we may not see that patient again, and I try to get the most information to give back to the referring physician. And the other thing that's sort of interesting in this older paper, there were a bunch of patients that started out, there were responders and non-responders, and you can see here's all the responders, and then they got tested again, and a lot of those became non-responders. They got tested again, and the responders became responders and non-responders. So the problem is, depending on when you get these patients, and I'm sure you've all seen that in your practice, that there's a lot of variability in COPD and in asthma as well, in terms of how people respond. And one day they're going to be a responder, one day they're not. So I kind of think that if you see those patients, I try to encourage people to get bronchodilator therapy if there's any reason at all for it. I'm not sure if you all would agree with me on that. Anyway, when we look at pulmonary function tests, we look for a change, looking for absolute changes and so on. And let's say a word about diffusion, much more complicated than just spirometry, which I know was fun for everybody to look at. This provides a quantitative measure for gas, measures transfer of carbon monoxide, and often abnormal in patients with ILD, pulmonary vascular disease, and COPD. There's molecular diffusion and chemical combination with hemoglobin, and I'll show you that. Here's my cartoon of the day, where there's the alveolus, there's the idea of carbon monoxide and coming across, and oxygen, and there are red blood cells moving along here. So in order to measure the diffusing capacity for carbon monoxide, the carbon monoxide must come across and attach onto the red blood cells. And here's the close-up look of that, where there is the knowledge that oxygen and CO2 compete for the same binding site, and there is such a high affinity for carbon monoxide, it's preferentially attached to the red blood cell. And the next slide kind of goes through this. Both CO2 and oxygen readily diffuse across the membrane. CO2 has a much higher binding affinity, and CO2 tension does not increase, so there's no back pressure. So CO2 uptake is entirely diffusion limited, and O2 is perfusion limited. So we use CO2 as our gas to see how much is taken up and what will give us a diffusion test. Now you can look at diffusion, and depending on the alveolus and the capillary, this is normal emphysema, you have no alveoli. Here's IPF, where you have scarring, and here is lobectomy, where you have less surface area, and here's a vasculitis, where you have bad blood vessels, so you don't have the ability for the transfer to take place, and heart failure, where you have too much fluid. So this is just to kind of give you an idea that diffusion can be helpful in all those areas, and I try to make, when I look at pulmonary functions, some kind of a correlate if I can. And here's something that if you were all taking a test right now, you would look at it and I'd get your answer. All of these different disease states can cause an isolated reduction in diffusion. Pulmonary hypertension, emphysema, obesity, early interstitial lung disease or anemia, and of course the only one that doesn't cause an isolated reduction is obesity. Pulmonary hypertension can, mild emphysema, early interstitial lung disease, and anemia. So when I'm looking at that, and I'm looking at those numbers, I try and utilize diffusion as a way of either making my case less or more strong for one of these diseases. Often drugs can do it, like amiodarone. There's a lot of things out there. All the chemotherapy agents, you know, there's every time a new chemotherapy agent comes out, there's always the statement that it could cause a pneumonitis. So that issue is always going to be there. All right, let's move quickly to exercise so we don't miss the fun of that. First, we start with 6-minute walk. I think that could be in any office. Safe, simple, practical. Gets better with lung volume reduction surgery, pulmonary rehab, and outlines when your 6-minute walk test is good, your mortality is better, you don't go to the hospital, and so on. There are, once you get to the top of it, you don't get any better. You pace yourself, you standardize your walkway, hallway length, so patients go up and down a walkway, they're with a nurse, they measure heart rate and oxygen tension, and they measure the work of breathing, and they can follow that with adjustment in drugs for people with IPF and other things. and this is a slide that's even very fancy for me, where you can see that with COPD, pulmonary hypertension, interstitial lung disease, and other chronic lung disease, that the mortality risks would go up with, or let me put it another way, that the mortality risk would go down with a longer 6-minute walk. So with COPD, if you can walk more than 300 meters, with pulmonary hypertension, 330 meters, and so on. If you were less than that, your outlook was not near as good. And so you wanted to be able to interact with those patients. So 6-minute walk test can be helpful and can be put easily in most every office. It just has to be done the same way each time, and you have to be able to measure it. A 10% change in the meters covered is felt to be a positive test. And that's where we are with that. However, now I get to the part where I spend a lot of my time with is the gold standard, and I've only saved 2 hours for this, so that's good. The CPET is the gold standard. It is a more complex test. It assesses the pulmonary response, the cardiac response, and the musculoskeletal response. And so it can find out causes of limitation that you just don't see with any of the other studies. You look at it for unexplained shortness of breath, when there's activity limitation, when you're deciding whether it's a cardiac or respiratory limitation, when you're assessing disability, when you're doing a preoperative assessment, when you're looking for a transplant, functional assessment, you do exercise testing. So it's a busy issue. We have patients either use a mask or a mouthpiece, and some people like the mask, although it's tight and not very comfortable. The mouthpiece, though, you are having trouble with the secretions with exercise, and as such, there's a little spit tube there that can become kind of messy. So you decide which one you want to use and kind of stick to it in your lab. The lab ends up putting patients on a bike 5 to 30 watts per minute. And so you can, if you're up to 25 or 30 watts per minute, you can get to a fairly high watt level quickly. And you have the tech and physician in there encouraging the physician here, encouraging the patient. And here's the patient working all with this monitoring. There's a lot of data that comes real time, and I'll show you some of that data. The referral is something we look at. We look at all these values that I talked to you about. We ask for the rating of preserved exertion and Borg scales to look for maximum effort. We measure all the ventilatory response, ABGs, and with COVID, I can't help but tell you that it has changed the world of exercise, because there is massive amount of air as people go up to exhale minute ventilations of 60, 80 liters per minute, and that air's got to go somewhere. And so it's caused us to redo totally our exercise labs to not contaminate everybody in the region. But we do the same thing about trying to keep the lab cleaned out. No visitors, no friends, no maintenance workers in the lab. And then we look at why people, may stop maximum work. We look at that, cardiovascular, O2 pulse, heart rate reserve. We look at breathing reserve, O2 delivery, lactic acidosis, when they become acidotic, gas exchange, and so on, and oxygenation issues. This is just a note saying that if you looked at people with different kinds of diseases and you said who had the best exercise ability with increased risk of death all across the board, whether it was hypertension, COPD, diabetes, smoking, elevated BMI, elevated cholesterol, that your risk of death was going up when your MET level or your oxygen uptake levels were falling. So that your risk of death here when your MET level was less than 5 was way up here, whereas if your MET level with hypertension was greater than 8 was down here. And I always believed that if we did more testing like this, we would be able to look at patients in a more predictive way, get people to stop smoking and to take their blood pressure medicines and so on, because we would change their exercise abilities. That doesn't always happen though. So here's my last point here. This is a patient that I saw with a history of stable cardiac issues, Ehlers-Danlos syndrome, shoulder pain, rotator cuff surgery, right cervical neck pain, and had a cervical neck block in February of 2018. Within weeks, increasing limitations with activity, always active, loved to do landscaping work around her house, had a commercial real estate type job, garden, insignificant smoking history, no allergens, on a couple drugs. And we worked this patient up and found out what was wrong with her. Her lung functions, take it from me, are normal. Spirometry is normal. Total lung capacity is a little bit reduced here, so that may be a bit of a clue. And diffusion was normal. So maybe mild restrictive disease. You all would agree with me that that full volume lift looks really normal there. No problems with takeoff time there. And that chest x-ray is normal in the past. This is in 2014. So nothing in 2014 for any clues here. Then we looked at exercise tests, and this is how we determine things like anaerobic threshold. We look and see when ventilatory equivalents for oxygen start to go up and CO2 stays stable, and tidal oxygen, CO2 levels stay stable here, and oxygen goes up, related to the needs of anaerobic threshold. And I'll show you the blood gases that demonstrate that. We looked at full volume loop, and you would say, well, gosh, maybe there was a mechanical point. Inspiratory capacity tends to get worse with serial spirometry with exercise, and this inspiratory capacity stayed stable, and the full volume loops didn't become abnormal with exercise. So I thought maybe she had a respiratory issue, but it did not turn out to be respiratory. But I thought, maybe this lady has a problem going from upright to supine. And in fact, she did. Her FEV1 fell from 2.08 to like 1.53. So what could make her FEV1 fall when she goes from upright to supine? And to make sure this excitement doesn't last too long, I will give you the answer. But this was more the definitive test here with this lady, that when she lied down, her mechanics became worse. But yet post-exercise, she didn't have more asthma here. You can see her FEV1 was 1.5 to 1.9. So you can see it wasn't that asthma got worse, but when she lied down, it got worse. And here's her blood gases. Pre, she was 7.4, 37, 74. And we always do pre and post blood gases, meaning that we anesthetize the wrist. I do a resting blood gas prior to exercise, and then I do a peak blood gas. And you can see pH went from 7.4, 7.3, and with that, the bicarb fell as you would think it would, and lactate went up. So this is a maximum test. She increased her rest lactate from 0.3 to 7.2, so highly motivated, and oxygenation certainly isn't the problem. Her PO2 went from 74 to 111. So we know that she gets worse lying down, but she ended up having no other abnormalities that we've really seen here. Here is something that we should look at, and I get this as one of our plots. This is minute ventilation over CO2 production, and those of you who know the name Karlman Wasserman, he is the father of exercise. He is now in his 90s. He still is active. He has had a neurological event where he can't speak quite as well as he should, although I think he still speaks better than me. He helped develop these panels, and here's where CO2 production is compared with minute ventilation, and this curve should be at a value that looks kind of like that, a more flat curve, and that minute ventilation or over CO2 should be around 25. Here, her curve was around 34, meaning it was too steep. And the takeaway message here is that her breathing was faster than it should be for all levels of exercise. It meant that she had to work harder to blow the CO2 off, and that made her short of breath. And the reason she did, I will get to in a moment. The machine that we have gives you a peak VO2 max, and her fitness is based on that, and her VO2 max was about 16, and we can look it up here, and it tells her she had moderate to severe impairment, and kind of right in the peak of that. So she did have impairment that our fitness category looks at. So we know she's not as fit as she should be. She's short of breath. What happened when they stuck the needle in this phrenic nerve? This is kind of what happened here. The C3, C4, C5 are the different segmental nerves coming from the cervical spine that meet together to make the phrenic nerve. Now, this person who was doing her nerve block was way away from wherever they should have been back in the spine and decided to do the nerve block here. I'm surprised there wasn't a big bleed from, the subclavian vessels and so on, but this person ended up having a damaged phrenic nerve. So as it says here, the phrenic nerve arises and traveling along the anterior scalene muscles. So they were way out of sync of where they should have been. So this person had a phrenic nerve injury. And here's the way the diaphragm looked. The diaphragm was way up here after the phrenic nerve was lost. So she lost all the function of her right diaphragm. That's the 2018 X-ray, and that's the 2018 CT scan, where way up at the mid-chest level is where her diaphragm is. This is the left side showing no problems with that. So that was the problem. Her limitation was related to pulmonary vascular hypertension because of diaphragm paralysis. The mechanism is increased cardiac output with exercise with a limited pulmonary vascular bed because the right lung was limited in its ability to take the extra cardiac output, so that she ended up with pulmonary hypertension. Her right heart pressures went up. No therapy was available. And that's the end of it. So this is not ski season, but my point of saying that if you do become a daredevil with skiing or want to do more heroic things like climb Mount Rainier this summer, an exercise test is a good way of knowing what your capacities are and what you need to work on. So with that, I'm finished, and I'm happy to answer a question or two. I'm not sure how that works necessarily with Zoom or how you want me to do that.
Jeff, thanks very much. I have a question for you. When we're just doing routine office spirometry in our Northwest Asthma Clinic, very often we have a clinical diagnosis of asthma and we have spirometry that shows restriction. How do we explain that? Is that technically that we haven't had a good test, or what other answers are there for that?
Well, then I think there's lots of things. I mean, if you've met all those criteria that we've talked about, and they're, reproducible tests, and you've gotten 3 tests within 150 cc's, and you end up with restriction based on a low force vital capacity but normal FEV1, then I think you have to work that up as restriction. And like those slides that I showed you, you end up having to do plethysmography or other studies to look for primary restrictive disease, because if you have vital capacities that are below the lower limits of normal, you have a pretty good chance of having significant isolated restrictive lung disease. But if you don't, you can also get restriction when you get a less than full effort, and you get FEV1 that's reduced and the force vital capacity that's reduced, and then it'll look like restriction when it's all technical. Now, that new equipment that I mentioned to you will be giving you a sign that you have had the right flow volume loop, that you've had the right, that there's been nothing that made the patient work less hard than they were supposed to, that prevented adequate measurement with coughing and so on. So I think you have to decide, was it an adequate test? And if it was, then you have to go down the pathway, and then I would order full pulmonary functions. I would do lung volumes and I would do diffusion, and that way you can start to understand, is there parenchymal lung disease that needs to be worked up separately from, and that doesn't mean that that patient doesn't have asthma as well, but that there's more of a restrictive pattern on pulmonary function tests that are dominating the values you get.
When you say there's new equipment, are you talking about very sophisticated pulmonary function lab like you might have, or are there certain manufacturers, certain companies, if you want to mention, what we should have in ambulatory outpatient spirometry?
Yes, I think that Sensormedics and Medical Graphics are the two that I deal with most. And when you buy a spirometer through them, and there are $4,000 to $5,000, they are Epic compatible. You can put in any of the predicted equations you want. They will automatically tell you and the tech, whether there were all those different benchmarks were made, and let you know whether they're adequate. And you'll be able to sit down and say on a test like that and say, well, can you show me how many, was this an A, B, or C test? Were there 3 producible curves that were within 150 cc's, or were there 2 reproducible curves that were with 250 cc's? And that's baked in to all these new spirometers. The older ones don't have it, but that's why this new paper, the 2019 paper, spends so much time on what these new spirometers will have, which the hope will be that it will make spirometry more user-friendly by telling the tech what they need to look for and throwing out stuff that is C, D, that you can say, well, accept A and B, but we don't want anything that gets rated below that. And it's not having to buy plethysmography or diffusion. It's just getting the newer equipment that has all these checks and balances built into it electronically.
Well, thank you again for this. Anybody else have questions before we sign off?
Okay, well, thank you.
Yeah, I actually have one real quick, if you don't mind. I'm a PA in a new allergy asthma clinic. Well, a new PA in an allergy asthma clinic. I was wondering if you could, I don't mean to put you on the spot here, but if you could speak a little bit about the forced expiratory flow 25 to 75 in regards to obstruction or the use of that metric.
That has been debated forever. I believe that the FEF 2575 or mid-expiratory flow rates, if they are reduced to like 60% or so of the forced vital capacity, should be taken as reality in patients who are sick, who have a cough and shortness of breath, and especially in patients who reverse that number with bronchodilators. So, and that's kind of relevant to what I was saying about how when I look at a patient and we get one look at them, that if their FEF 2575 is down and they would have mid-expiratory flow rate abnormalities, that you should see if that reverses with bronchodilators, because that's somebody that has a cough often or has some very sort of vague pulmonary complaint, and that the best you can do is say, well, that person got 30% better in their FEF 2575, and I am going to try some bronchodilators in that person. So I think that should be done. I can tell you there's a large body of people that believe there's too much variability, that the standard deviations are too wide, and they don't want that shown. But I don't see it totally removed from the equipment at this point yet. I have been to conferences where they consider you as somebody that should not be allowed anywhere in the first half of the audience if you believe in FEF 2575. But I still believe that a reduction in that, especially with improvement in that with bronchodilators, should make you think about a component of reversible small airway disease. We've always said that value goes down with smoking as maybe the first sign of abnormalities, and I still think that consistent with my goal of trying to get the most information out of a patient on spirometry and to give that to the referring doc, I still think there's a reason to be aware of that. But I don't share, there are a lot of people that don't share my belief about that.
Jeff, again, thanks very much. Very excellent presentation. And I know everybody in our community can contact you as a resource, especially what you're doing now in the COVID problem, clearly dealing with that in our practice.
Yes, I think we've spent a lot of time on COVID and trying to get things back open, but boy, it's such a change from the old environment of the surroundings of the pulmonary function. That's why I wanted to bring that up to you and let you know what we've done. And I will say there's no standard around the country. I've read the Mayo Clinic approach and other approaches, and I've seen some people that demand that a COVID swab be done 48 hours before the test, and other people just say no, not unless they're symptomatic by the viral screen. So I think it still hasn't, sort of totally worked itself out, but our goal is to have been more conservative and then ease up if it looks like we're doing too much. And so we'll see if we were on the right track or not.
All right, take care. Thanks again.
All right. Thanks very much.